me tell you a little bit about myself. I am a board certified family medicine physician. I'm from right here in Richmond, Virginia. I did my training at University of Virginia for my undergrad and medical degrees, and then went on to complete my residency in family medicine at the University of North Carolina at Chapel Hill, and of course became board certified in family medicine. Family medicine, for those who may not know, is the field of medicine that is primary care for both adults and children. So we see people from cradle to grave or womb to tomb. We're trained in OBGYN care, births, deliveries, infant care, children, and on and on and on. Right now, I practice just outpatient family medicine care. So currently just seeing 2 years old and up at Commonwealth Primary Care at our West Creek location, which is located out in Short Pump. I also work with a local group called Virginia Care Partners on their quality committee that helps to improve cost and quality among medical care locally. And I'm also an assistant clinical professor at VCU School of Medicine in the Department of Family Medicine. So these are our objectives today. I hope that you'll be able to walk away with some sense of all of these topics. I will try to create a version of this that I can share with Deacon Battle so that she can share this with you for reference. But I'd say try to take away just some kind of this structure here of I'm going to go over some medical terms that might be helpful to know. Those details you can always reference again. You can ask your doctor these details, but I'll give you some reference there. Then we're going to define what advanced care planning is, why it matters, who is involved, what do you actually need to put in these documents, and how do you document it? And then again, some time for questions at the end. Okay, so some medical terms to know. Don't be overwhelmed by the number of things here. Again, these are details that you can talk about with your own personal physician in detail if they ever become necessary. But let's just do an introduction here. So breathing support is something you might hear about as I talk about this. Those are different types of devices that help you breathe. Sometimes that's temporary, sometimes it's permanent. You might have heard the words ventilator, which is, or respirator. Those are machines that help you breathe. You might have heard the word intubation. That is where they use, or we use, a tube to protect your airway. So it goes through your mouth into your breathing tube, and therefore the air can get in and out of your lungs. There is tube feeding and IV nutrition, so IV meaning intravenous. So there might be times when people, again, either temporarily or permanently need tubes to help them eat. So instead of putting food directly in your mouth and swallowing, sometimes that has to go through a different device because people cannot swallow, or perhaps there's some problem with their mouth or esophagus. You might hear of a nasogastric tube, so from the nose to the stomach, a G tube that goes right to the stomach, a PEG tube. These are all just different names, and they have to do with where the tube goes in and where it is emptying the nutrition into. Many of you have probably heard, pardon my typo here, intravenous fluids. So just IV fluids, those can go in through a peripheral IV, meaning like when you get a IV fluids placed, if you've ever had that done, and then a central line. I'm sorry, here I added this morning to help clarify, but central line is what that's supposed to say. Those are big IVs, basically. They go into big blood vessels around your neck or your groin. Antibiotics, most of us have probably had those at some times. These are medicines, sometimes oral, sometimes IV, that are meant to treat bacterial infections. There are other medications that you can get through your IV. Dialysis, some of you have heard of. This can be temporary and sometimes can be long-term. And this is about supporting your kidneys. So another really important organ, if it's not doing its job well, we can do it outside of the body with dialysis. And then surgery, of course, there are several types of surgery with different purposes, but good to think about that as a type of medical care. And then finally, imaging. So that's all your pictures, right? Is there a need for x-rays, a CT scan, an MRI, ultrasound, and other types? So those are just some general medical things to kind of orient you to words you might hear. So now, advanced care planning. What is advanced care planning? Advanced care planning is all about your future medical decisions. This matters while you are alive. This is not for plans after death. Those things matter, but this is not that. These are not funeral plans. This is not estate planning. This is not your financial power of attorney. This is specific to medical decisions in your future while you are alive. Um, And then more specifically, this only matters if you cannot speak for yourself. So if you are alert and coherent and you can make your own decisions, it doesn't matter. Your medical team will ask you what you want to do. But if for some reason you cannot speak for yourself, then that is the point of the advanced care planning. This might happen in an unexpected medical emergency. It could happen because you're unconscious in the middle of a surgery that was planned, but now something new has come up and they need to ask someone what your preferences would be. And it often comes up in end of life care. If you've ever helped care for a friend or family member at the end of their life, you might have had firsthand witness or firsthand experience with the types of decisions that come up, and perhaps you've had to be the one to make those decisions. So this matters when you cannot speak for yourself and someone else has to do that speaking. Sometimes people wonder, oh, I don't want to say this because what if I change my mind? That's okay. You can update this anytime, as many times as you want without end. So a key part of it is staying up to date. And I encourage you to be constantly thinking about your preferences so that you can be updating your people and your thoughts and goals. So don't let that deter you. You don't have to know what you want 5 years from now or 10 years from now, or even a year from now. You just want to think about what best suits your current desires and wishes. And then in terms of the hard copy, what does this physically take the form of? It is going to take the form of a legal document or a medical order, and we'll get into what those look like. So why do you need to do this? This is all about personalizing your care, making it what you would want. The goal is that someone can do their best to speak on your behalf if you literally cannot say those words or write those words. This is guidance for your loved ones and your medical team. There are so many different ways to manage your health, just like so many decisions that we have in life every day. There are tons of decisions that you can make with your medical care, and people have very different preferences. So I would not assume that, oh, they'll just do what's normal or what's typical or usual. Sometimes there's not a typical or usual. We want to know what you want so that we can honor your preferences. We want to know your values and your goals. And as we go through this, you might also consider, are you the healthcare proxy for someone? Has someone designated you to make their medical decisions if they can't speak for themselves? And therefore, do you know the same thing about them? Okay. So as you are practically putting this together, the first thing to consider is, who do you want to make your decisions for you? I strongly recommend choosing a primary decision maker and a backup or secondary decision maker. You can appoint multiple people as primary and multiple people as secondary. I've heard some lawyers say, it's best to make it one, but from my perspective, I'd say make it whoever you need that you feel is going to do the job well. So that could be an individual or a combination of individuals. They do need to be an adult, so technically for this, 18 or older. And they need to be accessible. They do not have to live with you. They don't even have to be in the same state. They just need to be accessible. So if they live in Alaska, but we can call them, okay, that's fine. Now, if they live in a remote area in another country and we cannot get them on the phone, that may not be a good fit. So they don't need to be immediately physically present, but they do need to be accessible so that your medical team can call them or talk to them if they need their input. And questions, I think, when you're trying to figure out, well, who do I want to ask? You want to know who could speak for you when you cannot speak for yourself. And if that person is not available, who else do you want? That secondary is really important because sometimes that primary truly is not available. What if they were involved in an emergency? What if by chance they have passed away before you updated your document? So always, if you can, and sometimes it's challenging to have a secondary, but if you can, I think it's a great idea. So you've chosen your people. Next, talk with them. Do they know that you've chosen them? Are they willing to do this? And then do they know what you want? It's one thing if you said, oh, yeah, my daughter will do it. But if you've never talked to your daughter about these things and she has no idea what matters to you, it's going to be more challenging for her to serve you well. So talk with them. Most of the time, I can't think of any experiences where I've seen family members decline when a loved one says, will you be my decision maker? But I can certainly imagine that that could happen if they're truly uncomfortable. So you want to make sure they're on board and then have these conversations. This is another point that sometimes stops people from moving forward. They feel intimidated by the conversations or unsure what to do, how to have them, or maybe the recipient, the decision maker is uncomfortable having them. Have them. On when people need to actually use these services, I tend to find that family members are more thankful that they have had the challenging conversations than not. It is one thing to deal with maybe a parent or sibling or spouse passing away, but if you know what their preferences are and you feel like you can enact them, that's a whole lot easier than having no idea which way they'd want their care to go. So the conversations certainly can be challenging, but they are so worthwhile. They might even help you think of some things you'd want for yourself. At the end of this presentation, I do have some resources, including some guides to have those conversations if you're unsure where to start. And then write them down and update them, as I was talking about. I'd say at least every couple of years, think to yourself, are these still the people that I want? Are these still the goals that I have? What you want for yourself, I know this group is usually in their 70s and up. What you want for yourself at 70 may not be the same thing that you want at 80 or 90 or 100, or even at 75 or 85 or 95. So consider that and continue to update. Now, what to consider. This part is a little bit more detailed, but this is the part I think sometimes we don't get to talk about. Like, what is it that I'm really deciding about? This can sometimes, again, be something that stops people because they don't know. I don't know what I want for my medical future. Don't worry so much about the details. I'm going to discuss these with you as an opportunity to see where things can go, but don't stress over these details. For most people who are in their kind of baseline state of health, maybe you have some chronic medical conditions, but they're generally stable and well managed, people's goals will be very general, and that's appropriate. You do not have to think of every single medical condition or outcome that could happen and your if-then statements. So if you're in kind of your typical state of health, even with chronic conditions, even if they have symptoms, it's okay if your goals are general and vague. But if you do have some specifics, then it's worth noting. And as people's health can become more challenging, that's when these details start to matter more. Again, if you've had to work with a family member through this, some of these details might be familiar. So note these. You can use this as a reference point. These are things you might have preferences for in the future. So let's talk about code status and CPR. I kind of broke these down into different levels of care and how sick somebody is. CPR, which is cardiopulmonary resuscitation, this is immediate care. This is when someone has cardiac or respiratory arrest. That means their heart is not beating or they are not breathing on their own. For instance, a football player who fell, who passed out during the football game after being hit, he had cardiac arrest, and then you saw the trainers start CPR. So sometimes people confuse this with life-prolonging measures or even treatments. This is not the same as staying on a ventilator or receiving dialysis for a long time. This is in the moment. If someone falls out, as I say, and they don't have a pulse or they're not breathing on their own, what do you want to happen for your body in that moment? Do you want someone to provide CPR or not? That is your code status. What does CPR involve? It involves a few topics here. Chest compressions, as you probably saw, if you ever seen it, like for the football player, that is literally using our hands to press hard and fast in the center of the chest. We're trying to make your heart, we are trying to beat for your heart. basically with that, to keep your blood flowing through your body. It involves breathing support. And depending on where this happens, different supplies will be available. So if you were out on the football field like that gentleman, you might see someone like this woman use a mask that she can breathe through with a filter. But if this happens in the hospital, they're going to have more advanced equipment. So they might use a bag and other things. But chest compressions, breathing support of different types, and a defibrillator. These are available in lots of community spaces now, definitely available in the hospital. They'll put the pads on, and if certain things are happening with the heart, then a shock can help get it back together. So they'll do that. And if you're in certain settings, the team will use medications to try to get the heart and breathing back in order. So that is what CPR means. So if you fall out, as I say, and you are experiencing cardiac or respiratory arrest, do you want these things? That is your code status. Now, if you are out in the community, you don't need to tell anybody your code status if you want those things. That is the standard of care. We call it full code. If someone falls out and the ambulance is called and there is no indication otherwise, you are going to receive CPR. That is the standard of care. When you go into the hospital, you might notice they'll ask you what you want because they make it in order, either full code or do not resuscitate or something else. But if you're just out in the community, if you want CPR, you do not need to do anything extra. That is what will happen. Now, if you do not want to be resuscitated, then that is a medical order. That this is a type of advanced care planning. It's a particular document I'll show you later, and you can have that apply to you while you're out and about in the community. For most people in their usual state of health, it may not be it's not a good fit right now. If I had cardiac arrest, please try to resuscitate me. But some people, for many different reasons, a common one might be that they are critically ill and they don't want to put their body through resuscitation. It is very physically strenuous, or perhaps they've had that done before. Perhaps they know that if they survived it, that they're worried they might be in a more critically ill state, right? So if for certain medical conditions or certain people, if they know no matter what, they do not want that, then we can write this order. This can happen with your regular primary care doctor. We'll talk about it, make sure you understand, sign it, and then you can have that apply to you. And you can change your mind. If you change your mind, it's as simple as moving the paper away, tearing it up, taking off the piece of jewelry, or however it is that you've designated it. And that is something, if you feel like you would like that, definitely worth having that conversation with your doctor. And then you can get into the details of why you would like that. Do you understand what that means, what the other options are, and so forth. And then I wrote other here. In the community, you're pretty much full code or do not resuscitate. But if you're in the hospital for a surgery or an emergency, sometimes there are some other options where you can pick and choose pieces of this, of the CPR. But generally, when you're out and about living your life, it's either full code or do not resuscitate. So next, is thinking about what would you want in terms of life prolonging care. So this is what I was saying, sometimes people confuse with their code status. So at this point, maybe you survived CPR and you have some key bodily function that is not doing what it needs to do anymore. So we are using some type of medical therapy to try and do that job. So perhaps someone's lungs are so ill that they can no longer breathe and oxygenate their blood well, so they are on a ventilator. Maybe they have had some sudden severe kidney injury and they are on dialysis and they are never going to get off of dialysis. Those things in this case are life prolonging care. This is care that does not lead to recovery. And this is where people tend to have more questions about, well, I don't know if I'd want that, or don't leave me on these machines, right? Or don't keep me alive. So here you want to think about, what would you want? What are the goals or values that help you decide how long you'd like for someone to try? And this again is where having specific conversations, maybe even with your doctor, can help you figure out what is it that you would want or not want. So for instance, on one common medical directive form that's like a pre-filled form, this is how they'll bring up these types of situations. They use the terminology as in number one here. If my doctor determines that death is imminent, meaning close and likely, medical treatment will not help me recover. It goes on to say, like, what would you want? Or another condition or another situation here might be if my condition makes me unaware of myself or my surroundings, or unable to interact with others, and it is reasonably certain that I will never recover this awareness or ability, even with medical treatment. Again, dot, 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 what would you want? All right. So this is one that's worth thinking about. And then what does that mean? These are some of those terms I was talking about before. How we do that, what is the care that does not lead to recovery? Sometimes it's these details. Sometimes it is, again, a ventilator or tube feedings or IV fluids, CPR. We can keep doing CPR. It may work sometimes, it may not work other times, so we can continue to try if that is consistent with your goals. Do you want to keep receiving antibiotics? Do you want to keep considering pursuing dialysis? And key point here, this is not about pain management and comfort. Those things will always be provided, but what do you want in terms of care that is keeping your key bodily functions going? Okay. Now, separate is just medical treatment. As I have alluded to, sometimes these same treatments, the breathing tubes, the dialysis, medications, and even a G-tube, a tube to help you feed, sometimes those are curative, right? So sometimes we are offering a care that will actually treat or cure a medical problem, so that maybe you can take out the G-tube and go back to eating. Your kidneys recover and you can get off dialysis. Your lungs may be very sick, but then they do get better and you're able to get off the breathing tube and breathe regular air all on your own, right? So there you might also consider, are there things that you know you would want, things that you would not want? How long would you want them? And here, again, that's where your personal values and preferences will help you decide. A common example they'll teach us in medical school, and I have seen this happen in reality, is perhaps a Jehovah's Witness, because of their beliefs, will decline receiving blood products. So that's not usually anything heroic in terms of medical treatment. It's pretty typical to give people blood products if they need them. But in this case, that blood products or a blood transfusion could be a curative treatment, but someone may say they do not want them because of their religious beliefs, right? And it's not about keeping something alive or prolonging an inevitable death. It's truly just a treatment, but they have a reason that they do not want that, and we can honor that. All right. And so just like last time, which can seem a little confusing, what is it? It's very similar things. The only difference is what the goal is, right? Is this going to be IV medication that we can give you and then things get better, right? So the medical details can overlap. Maybe cancer is involved, maybe there's radiation treatment or chemotherapy. But again, I have met people who say, I don't care. I don't want chemotherapy for XYZ reason, or it doesn't matter. Even if it could cure it, I don't want radiation. So you can pick any of these. And even if it's going to cure or treat, you can say no, or you can say, I would definitely want these things. Then another scenario, so we've talked about cardiac arrest, that's a very particular moment and code status. Then we've talked about life prolonging measures. So that applies when death is imminent, likely and soon, but perhaps there's things we can do to keep the body alive. And if we take them away, then death will likely come. And then there's things that help you that could be temporary. Then a final scenario to consider is actually end of life. We'll all meet this point, and death can look so different. Sometimes it is quick and without any warning, and there's not time to do anything really different. Sometimes it is prolonged and there's lots of time to plan. So the key question here is, what do you want your medical care to look like at the end of life? Again, knowing we don't know the details. We don't know as doctors. No one has an expiration date on the bottom of their foot. We just try to give our best care in between. But if you had a choice, What do you want your medical care to look like? Because often we do have a choice. Here I mentioned hospice because this is another of those words that people sometimes get scared of or worry about. Oh, that means that I'm going to die. That's not quite the case. Hospice is intended for people who are critically ill and who have a life-limiting illness. If that disease took its usual course, people in hospice could likely die within several months, right? If the disease did what it usually does. But hospice is not killing you, okay? Often people feel better when they transition to hospice. The key with hospice is that it is about comfort. So instead of saying I'm going to use cancer as an example. Maybe there's a very severe advanced cancer, and instead of saying we're going to try to do chemotherapy and radiation to make the cancer go away, if we say that those things are no longer helpful and the patient wants hospice care, now it's all about keeping that patient comfortable. It could sometimes still include similar medical modalities. You can get chemotherapy, or I'd say maybe you can get radiation or sometimes surgery just to help a symptom. Maybe a tumor is pressing on something, and if we get that tumor smaller in size, then you'll be more comfortable, right? So it's you really get to steer the ship. We're not trying to make a disease go away or make it better. We just want you to be comfortable. Can you breathe comfortably? Are you in pain? Are you nauseous? Are you vomiting? Can you move to the best of your abilities? Also, with it comes more support. Sometimes people don't recognize that. There's more nursing support and care managers, respite care, support for the family. And it can happen in many different places. Hospice can happen in your home. It can happen at a hospital. It can happen at a hospice center. People who are currently living at a nursing facility, it can happen there. So don't be afraid of that. The key thing is if someone that you know or yourself is at a point where they no longer want to pursue treatments, trying to make the thing better, and they want to focus on comfort, that is when hospice can be considered. And sometimes people consider it very late in the game. Maybe people are in their last weeks or days. Again, this can be considered months and months before death. So it does not have to be a last minute, final days decision. So don't be afraid of that and that conversation. You can enter hospice and leave hospice. So just like changing your plans for advanced care planning, that's something that can be fluid as well. If something happened and you said, no, I want you to treat this, they can end hospice. You can go to the hospital that night. So don't be afraid of that. Now, I'm running a little over here, so I'm going to move through these last few quickly and we can get to questions. One final thing to consider is where you receive your care. Sometimes people don't think about this. Sometimes, again, depending on how your health is, I have dealt with patients who are critically ill, and because of whatever their condition is, they are frequently in and out of the hospital, emergency department, hours and hours and over and over and over. And for some people, they might decide, I don't want to do this anymore. And that could be medically appropriate and within what would be okay for their care. So know that that is something that you have a say in. Are there places that you absolutely do not want to receive care? Or maybe it's something temporary, just like those medical treatments we talked about. You have choices in your care, pardon me here, including where it happens. So is there anything that would make you not ever want to go to a hospital or emergency department? What about rehab facilities, if that was something recommended? What about being home with various levels of support? And then there's other unique services that can help you get care. Now, even in the Richmond area, they're introducing something called hospital at home, where you might be sick enough to stay in the hospital, but for certain conditions, they will treat you at home. Nurses will come and so forth. So just think about that too. Do you have preferences on where you get your care? And then on to our final big topic here. How do you do this? It is either going to be a legal document or a medical order. For the legal documents, you can either come up with one on your own with a lawyer. There's usually a fee associated with that. Or there are tons of templates, including, again, some links at the bottom of this that you can fill out for free. All that you need included are your wishes, your signature, and the signature of 2 adults that are witnesses. You do not need to have it notarized or anything other than that. Then in terms of medical orders, as I mentioned before, there is a DNR in Virginia. It's called a Virginia Durable Do Not Resuscitate Order, or DDNR. This is a form. You can print it off online. Doctors' offices usually have them. And it is just a conversation with your doctor and some signatures. And in this case, just your signature. And a final one I'll mention is the post order. This is for someone who is very, very ill. So the person who is trying to make very specific decisions about some of those medical interventions I talked about, and I'll show you in a moment, it just gives you more opportunity to be specific. And again, you talk with your doctor, you get these things signed. And then share them. So you've done all this work, you've chosen people, you've thought about what you want. And for many of you, it might be very general things that, all right, Sue, I want you to make my decisions, and I'm just going to talk with you about what I want. I don't have many details to say. That is fine. That's probably the most common outcome of this. But if you've got those details, this is where you can put them. So share them with your doctors, especially your primary care doctor. If you have an unexpected emergency department visit, great. That's a good time to take it with you. They can load it in their chart. If you have a planned hospital visit, take it with you. Make sure your decision makers have a copy. If you decide to do a DNR at any point, you can get jewelry made so you can be on your person, so that if you were in the community and have an arrest, the EMS knows what to do. And within your home, it's a good idea to keep it somewhere that is easily accessible, especially a DNR, because you don't want an ambulance to come in and start to resuscitate you when you don't want that. Common places to leave that actual document might be your refrigerator or above your bed, so that EMS knows do not resuscitate. Okay. So I won't click here, but it'll be available. This is one site you can go to, and actually it has a fill in the blank basic Virginia medical directive. This is free. You fill in your info and you sign. This is what the DNR form looks like in Virginia. It basically says, I am capable of making this decision and I do not want resuscitation, and you and your doctor sign. This is what some of the jewelry can look like, and you can see even the sample prices there from this company. This is the post form. So this is that more detailed order. It talks about CPR, medical interventions, artificial nutrition. It gives you nice details. And this is one that you would do with your doctor, like the DNR. So what next? Now you get to apply this to yourself. Choose your surrogate decision makers. Think about what you want. It's okay if it is very general right now. Make it detailed if those details come up. Then have the conversations, document it, and share your documents. All right, I will stop there. What